A new nurse practitioner and living in Washington, D.C. And I'm so grateful to be part of this series that Reagan has organized. Everything has been so useful and informative, and I just feel very honored to be a part of that. And for the last 10 years, I've been working as a nurse, primarily with folks experiencing homelessness, people living with HIV. And so one of the things I've been very interested in is how to adapt evidence-based practice, guideline-directed therapies, how to make those accessible and more trauma-informed, how to reduce harm to folks in a clinical setting. So I'm super excited about sharing with you the way self-collected HPV testing can be used to help reduce harm and improve outcomes in people with cervixes. So let's get started here. So just to sort of start, I know that not everybody here is a prescribing provider working in a primary care setting. And so hopefully this information will still be useful to you. And I know that some folks are already doing self-testing at wherever they work based on the registration feedback we got. So that's great. And hopefully you'll get some sense of how to maybe make things more formal or more coordinated. Hopefully it's useful to everybody. And along the way, feel free to ask any questions. Maybe Reagan can tell me, since I can't see the chat, if there's anything that I can answer along the way. But just to make sure we're starting out with the same foundation, what is the current way that people get screened for cervical cancer? And that is the Pap test. And it's previously sometimes called the Pap smear. And the way that this test works is that cervical cells are removed from the cervix, and those are smeared on a slide and looked at by a pathologist who identifies if there's any abnormalities or precancerous cells in the sample. And in order to collect that sample from the cervix, a patient has to have a speculum-assisted pelvic exam. So that involves lying on their back on a table, putting their feet in footrests called stirrups, and then a mechanical device called a speculum is used to open up the vaginal canal and allow the provider to see the cervix more clearly. And then a sample of cells is taken, sort of brushed off of the cervix and sent off to pathology. And that's been the gold standard for cervical cancer screening since the 1950s. And really the widespread use of Pap testing has significantly decreased cervical cancer morbidity and mortality. So prior to the availability of Pap testing, cervical cancer was the #1 cause of cancer deaths in women in the US. And that has changed dramatically over the past 60 or so years. So that's good news. The issue is that despite those gains from widespread screening, Pap testing really isn't reaching all patients, and it's not reaching more vulnerable patients in particular. So patients of color, patients with disabilities, LGBTQ patients, gender diverse patients, immigrants, people living in poverty, and patients at the extremes of the age range of eligibility, so in their young 20s or in their early 60s, all of those folks are a lot less likely to be screened. And what's concerning about that is that most cases of cervical cancer are found in folks who have never been screened or are overdue for screening. So those populations that aren't getting served by Pap testing, those are the ones that are most vulnerable to developing cervical cancer. And as you can see in that little infographic on the left there, over the last, just under 20 years, the rates of folks who are overdue for cervical cancer screening across the general population, that number has just been going up across the board. And that last number there, the 23%, that's in 2019. So that is before the impact of the COVID pandemic. So you can imagine that it's probably much higher now because of some of the barriers to getting into care over the last few years. And over 4,000 people still die in the US of cervical cancer each year, including a disproportionate number of Black women. So while we've made some really great gains with the use of Pap testing, there is still so much to do in terms of reaching folks, screening folks, especially those that are most vulnerable. So in addition to the structural barriers to actually getting to the Pap test in the first place, all those things you can think of like transportation, insurance, having a primary care provider be accessible to you, all of those things, those are all barriers. And then there's just the nature of the exam itself. So the invasive and uncomfortable nature of a speculum exam is often identified by folks as the reason that they've delayed getting a Pap test or they've avoided it completely. And here I just wanted to highlight an article from 2021 that looked specifically at the experience of women who are experiencing homelessness, what their report was of their experience obtaining Pap tests in the past. And so this is a population that has low rates of screening and high rates of cervical cancer. And so what were they saying about their experience with accessing PAPs? The researchers interviewed them and tried to understand what their experience was. And for both women who had histories of trauma reported and those who didn't, all of them across the board reported that obtaining a Pap test was both physically and psychologically uncomfortable. And these are just some quotes from the article. So some women reported that the position during the exam was humiliating and embarrassing. Some stated that even thinking about it, actually just thinking about getting a Pap test was upsetting to them. Some people asked to stop the interview early because of that. And women in particular who had a history of trauma, they used even stronger language about the exam. They said that their last Pap was terrifying, that they were scared to death of being touched. And some folks said that it was overwhelming and nerve-wracking. So I think the point here is that even under the best of circumstances, just the sheer nature of the exam can be re-traumatizing for folks, is uncomfortable, is invasive. So maybe we could do better. And I think the CDC, they've been aware that that rate of folks who are overdue for screening, that number is increasing, and they know about the inequity in outcomes for cervical cancer. So I saw this announcement that last year they hired a comedian, Amber Ruffin, who's great. She was going to make this series called Under the Paper Gown, I think is the name of the series. It had like shiny production value, a series of, I think, 6 little like web shorts, as it says here, to embrace the awkwardness of gynecology visits and encourage folks to seek care. Which is all well and good, but I think what that brought up for me is that the word awkwardness doesn't even begin to describe the experience that some folks have in obtaining a Pap test. It's awkward for some and it's traumatizing for others. And I think that what we could do instead is just actually make the experience of getting a cervical cancer screening less awkward, more accessible, and more trauma-informed, instead of having to encourage folks to embrace the experience as it is. And what sets the stage for us to be able to do that right now is that in 2020, the American Cancer Society endorsed for the first time HPV testing every 5 years for all people with a cervix, age 25 to 65, as the primary method of cervical cancer screening. So no Pap testing recommended by the American Cancer Society. And that was a big deal. And I think a lot of providers, people working in healthcare, are still even adjusting to that idea that HPV testing can be the primary method of cervical cancer screening. And why were they able to say that instead of Pap testing? Well, since HPV is the primary source of cervical cancer, sort of the underlying cause of cervical cancer, testing for HPV in the vaginal canal really more accurately detects abnormal cervical cells, sort of getting to the root cause of those abnormalities. And it's therefore more effective at protecting people from cervical cancer. And it has a lower false negative rate than Pap testing, because it's not about a pathologist looking at slides and sort of subjectively interpreting them. It's really more of a light switch. Is the light switch on or off for the presence of HPV? Now, the United States Preventative Services Task Force, they have their guidelines, and they do include HPV testing for people over 30, but they don't match the American Cancer Society guidelines at this point. So you can see in the green box there that the current USPSTF recommendation is for age 21 to 29, that you could use cervical cytology, which is a Pap test, every 3 years for folks in that age range. And I think the reason that they haven't gone further with the HPV testing is that there is a higher prevalence of HPV in the 21 to 29-year-old range that will likely resolve on its own and not cause any difficulties. And so I think they were trying to avoid some unnecessary interventions, but at the same time, by not fully getting behind the recommendation of the American Cancer Society, they're not sort of setting up a national standard for accessible cervical cancer screening. So let's talk about self-collection, because I really think it can reach more patients because of this accessibility piece. So HPV testing, the swab for HPV testing can be performed by a provider or by the patient, either way. And there's actually no significant difference in the accuracy of self-collected samples compared to provider-collected samples. So it's not like the provider has some special gift at performing the swab that makes the results more accurate. A patient can just as easily collect it themselves and still be accurate. And as you can imagine, self-collected testing is vastly preferred by patients across a variety of backgrounds, whether it's a cisgender female or a gender diverse patient who has a cervix. Patients report that it's quicker, it's easier, it's more private, it's more convenient, it's less anxiety provoking, it's less uncomfortable, less painful, and that it's also more empowering. It feels good to be in control of that process, good to be able to do that autonomously at your own pace in a private space. That feels good to patients. And then sort of following that, if you're able to offer self-collected HPV testing when they've done trials of this, it results in increased participation rates. And what I think is really important is that the biggest gains in participation are seen among patients who were previously underscreened or had never been screened. So for patients that had already been following along, give or take the guidelines, going in for cervical cancer screening, those, you did see some increase in participation there too. They were like, oh, this got a little bit easier. That's great. But where you saw the most gains are among the folks who were not seeking out Pap testing routinely and had a sort of bigger amount of vulnerability. Those were the folks that saw more gains in participation, which is really great. And I just sort of want to reiterate here that the availability of self-collected HPV testing can really ultimately then reduce harm to patients. And to focus here in particular on transgender male patients, transmasculine patients. So while most transmasculine patients do retain a cervix, and if you have a thing, it's good to screen it. Many transmasculine patients, when they are surveyed, they report delaying or avoiding Pap testing due to the impact on worsening gender dysphoria. And Fenway Health has done a lot of research on this, and they found that the rate of folks being up to date, transmasculine folks are about 37% less likely to be up to date on their cervical cancer screening for some of those reasons. And in one study where they offered self-collected HPV testing, over 90% of transmasculine patients preferred the self-testing option, reporting that it caused less gender dissonance, less discomfort. And in particular, the role of exogenous testosterone in how this process plays out, I think is really important to highlight. So because of the impact of testosterone on like vaginal tissue cells, patients that use exogenous testosterone, they're up to 10 times more likely to have an inadequate Pap sample come back. So they do the Pap test, they come in for it, sends off to the lab. The pathologist says, I don't have enough cells here to be able to give a clear answer as to whether there's anything concerning. And the reason that that is really important is that that means that that person is recommended to repeat the test after that. And if you can imagine, as we've already sort of talked about, the Pap test in and of itself is a hard thing for many people to prepare for and follow through on. So you imagine somebody already who is worried about doing this, maybe has had a negative experience in healthcare before. They finally are like, okay, I'm going to do this. I'm going to get this Pap test. And maybe they do some of those things that are recommended to help make a Pap test more manageable. They bring in a loved one there to support them. They put headphones on, they're listening to their favorite music. They practice saying stop and go so that they're in control of that process. They go through all of that only to find that they have inadequate sampling at a significantly higher rate than other populations. And for me, that represents one of the greatest opportunities of HPV self-testing, because testosterone use has no impact on the accuracy or the results of self-collected HPV testing. So when you are asking patients who already have trauma to come again and again and repeat testing, that's just worsening the situation. You're not even going to potentially get a result that has any impact on their well-being. And I saw this in practice as a student. I saw providers get the result back for inadequate sample and say, oh, you got to come in for another one. And so I'm really excited about how, in particular, for folks that are using exogenous testosterone, that this can really make a difference in their outcomes and their healthcare experience. And also for folks that have had a vaginoplasty and have a neocervix, a neovagina, HPV testing is also more effective at screening for cell changes in those tissues than a pap smear, because the tissues that are used to create those organs, to do a pap smear and send those cells for cytology to be looked at under the microscope, sometimes it can be very hard to differentiate what are concerning cells. And the HPV test, because that's really what can cause a lot of those changes, it's just going to be more effective for patients in those cases too. So let's talk about how to do this in practice. And this is sort of my summary of the guidelines that I kind of keep in my head based on this evidence. And so you can sort of take it as you will. And I did include this little infographic just to point out, this is from the World Health Organization. And I just wanted to highlight that while there aren't any standards for self-testing in the US at this point, that HPV self-sampling, as they call it here, is really where the world is trying to go in terms of increasing access to cervical cancer screening. So some countries are trialing mail to your home tests, where they send a swab to people's homes and then they mail the swab back and they run that for testing, and they see if people will follow up after that if needed. So there's a lot of innovation happening in this. And while we don't have a standard here in the US for self-testing, I just wanted to point out that it's a conversation that's happening, innovation that's happening across the globe. But in terms of the sort of guidelines I use, the first is to just plan to offer all patients with a cervix who are aged 25 to 65 the option of self-collected HPV testing every 5 years. So that's just in line with those American Cancer Society guidelines, that 25 to 65 age range, HPV testing every 5 years. And instead of provider collected, you're offering the option of self-collected testing instead. And then for patients aged 21 to 24, you've got this little window where the US Preventative Services folks are saying you should start doing pap tests on them, but the American Cancer Society is saying wait till 25. For those folks, you could either offer them the self-collected HPV test, perhaps if they're saying there's no way I'm going to do a pap test, I don't want to do a pap test, you could offer them the HPV test instead. Or you could just defer testing until 25 in line with the American Cancer Society guidelines. That can be a conversation you could have with the patient. You can give them that information and you can sort of talk that through with them and see what seems best to them. And I did just want to highlight that there's not any evidence supporting self-collection for cytology only. So that would be if folks are thinking, so we've got the pap smear where you collect the cells and then you send it off to have the pathologist look at it. Why don't we just have a patient take a brush that goes along the cervix and we have them collect the cervical sample? And there's really not any evidence to say that that's the good way to go, because it's hard to instruct a patient on how to accurately get cells out of the center of the cervix. It's much easier with the HPV testing, which is just a vaginal swab, to be able to have folks do self-testing there. So if you're in a clinical setting and you're like, how does this play out on the ground? My recommendation is that you just use the same supplies and sort of ordering pathway if you're a provider as you would for provider collected primary HPV testing at your particular clinical site. So at my last clinical site, the way this looked was very similar to the tools used for pap testing. You would have your thin prep file, which is like the little transport medium. We would have the flocked nylon swabs, which are sort of the evidence-based tool to use for the actual test. And the patient would rinse the swab in the little vial and we'd send it off to the lab. So whatever your system is for doing a primary HPV test, talking with the lab, communicating with them to see which is the particular test to order. Is it the Aptima? Is it the Cobas? Whatever that is, follow that pathway. And all you're doing is switching that instead of the provider collecting it, the patient is collecting it. And just one little side note with that, I imagine if you are working in a setting where you're ordering Pap tests already for gender diverse folks, you probably already have a system for how to make sure that LabCorp or whoever processes your labs doesn't reject a specimen, as it says here, a specimen labeled as a male gender. They sort of automatically will reject those. So you probably already have a system that works around that so that people who've changed their gender marker, maybe if you write in the ordering notes, patient has intact cervix, assigned female at birth, intact cervix, whatever your current system is for working around that sort of lab rejection issue, you would just want to do the same thing with HPV testing as well. So a lot of it is just using existing systems, and really you're just changing how the specimen is collected. And one important thing is that when they've researched implementing self-testing programs, patients are much more likely to find self-testing acceptable and they can manage it when education about how to perform the test is provided beforehand. Because one of the things patients reported being most worried about was whether they could do it correctly. They're like, okay, fine, I can collect my own swab, but what do I even do? Is this there's just sort of this sense that a provider could do it better. And that's not the case. They just need information to be able to do it in a way that gets an adequate sample. So this in particular is the handout from the Australian National Cervical Screening Program, which we'll talk a little bit about at the end of the talk, but it's very detailed. And I just highlighted in particular the specific instructions about how to, when you get there, to finally do how to do the swab itself, because that's what people really want some specific information about. And for how much to insert the swab, how long to rotate it for, maybe giving them a sense that it's going to maybe be a little bit uncomfortable, but it shouldn't hurt. All those things are going to really help patients feel confident to collect the sample. And at my last clinical site, what was helpful too is to just actually take out a swab and demonstrate just in the air. So folks even had a sense of just watching it made it feel a little bit easier too. So that's something that you can do. And what I want to highlight here too is that I think something that is really special about the perspective of trauma-informed care is that it's responsive care. So it's not a one-size-fits-all approach. It's not like, oh, well, we've decided that self-testing is actually more trauma-informed, so now that's the way it goes for everybody. It's really important that wherever cervical cancer screening is being offered, that folks continue to offer the option of provider-collected Pap and or HPV testing to patients. And that's because some patients, they're worried, as I mentioned before, about performing self-testing correctly. And so they prefer to have a provider collect the sample. Maybe they've been getting Pap tests their whole life, and it just feels like, I'm not really wanting to learn how to do that. I'm worried about it. And they just feel more confident having a provider do it. And then some folks are not able to do self-collection, whether it's due to physical limitations or cultural barriers. Maybe in their culture, they feel that part of their body to interact with it in the way that they would need to collect the self-swab, that's not something they feel comfortable doing. It remains important that they have that option to have a provider perform the test. And in addition, on the surveys that Fenway Health was doing with transmasculine patients, while the vast majority preferred to do the self-collection, there was a small subset of folks who said, actually, self-collection, testing, doing the HPV self-collection myself, it triggers more gender dysphoria in me than having a provider do it. Having to interact with that part of my body in that particular way to obtain the test, that is worse for me than having a provider do it. And so again, the importance of making this care tailored to each patient and what serves them best. And of course, it's important to continue to offer speculum-assisted pelvic exams when people have specific vaginal or vulvar concerns that need to be investigated. So when they've asked providers, do you feel comfortable recommending self-testing? A big concern that providers have is, well, who's going to check there? Who's going to make sure that everything's okay? Who's going to look in the area and make sure that nothing is wrong? How's that going to happen? And the truth is that when the U.S. Preventive Services Task Force looks at the evidence about doing screening pelvic exams, so just doing routine pelvic exams, not for any specific complaint, there's really not sufficient evidence to say that there's any value added in doing pelvic exams with any sort of like routine frequency. But they are helpful, of course, when a patient has a specific complaint. They have discharge, they have bleeding, they have a lesion they're worried about, they're having pain that they're not sure what's going on. All of those are reasons to do pelvic exams. And so it's still important to be able to offer those. But routine pelvic exams, there's not really the evidence to say that that's going to help their outcomes. And I think that that's one way that switching from the speculum provider exam to self-testing, it kind of moves us out of this like gatekeeper mentality as providers saying, oh, we're the only ones who can collect a sample. We're the only ones who can inspect that area and make sure that everything is okay. And releasing that and knowing that the evidence is there that actually the HPV testing has more positive outcomes in terms of catching cervical cancer, preventing cervical cancer, and just releasing that we need to sort of gatekeep that screening and giving patients that autonomy to do that themselves. And so to finish here, I just wanted to turn back to the what's going on in Australia, which is very exciting. Earlier this year, they made self-testing for HPV their primary method of cervical cancer screening for the whole country. So it's a national standard that everybody will be offered self-testing by their clinician. And of course, provider testing options are also available, but really the self-testing is the first line recommendation in terms of making sure that they're reaching as many folks as possible for cervical cancer screening. And because they also have a school-based HPV vaccination program, those two things together, sort of eliminating HPV infections through vaccination and doing a really good job of catching folks before cancer develops, they're on track to eliminate cervical cancer as a public health concern as a result of those two pathways sort of coming together. And that's really exciting. And so the reason I wanted to share that in particular is that I know that if there's not sort of a national standard for doing self-testing here in the US, I think that folks who want to do right by their patients, they might think, oh, I feel a little uneasy. Like I like to do things by the book, what the recommendations are. I really like to stick to that. And I really respect that. And I want to say at the same time that it feels like this is a little bit, this tiny little version of like John Lewis talking about good trouble. This is the type of thing that is really going to benefit patients. And even though there's not recommendations or guidelines for how to implement this in the US, like right now, it's happening around the world. And, you know, there's a whole country that is using it as their primary method of screening with really, really promising outcomes. So just to support folks to know that they're not doing it in a, if you were to implement self-testing, it wouldn't be doing it in a vacuum, and there's a lot of evidence to support it. So I did prepare this one little like one-page handout for folks just to support you if you're working in a healthcare setting, if you're a patient and you want to sort of see if your provider will allow you to do a self-test, because you can say, look, the evidence is there. They might not know. And so I'll make sure that Reagan is able to get that out to you guys after, but I just wanted to make sure that folks could have something in hand to work towards implementation wherever they are as well. So that's my presentation. I'm happy to answer any questions. Would love to hear any feedback. You can feel free to reach out to me. There's my email there. And yeah, thanks so much for tuning in.
Let me look in the chat to see if anyone has dropped any questions. I don't currently see one, but there's something that I wanted to mention, Liz. What was, I think in one of the slides, one of the last couple slides in the ad from Australia, there was someone in a wheelchair. And that was something that I wanted to include on the poster for this event too, because I think there's so much ableism in our healthcare spaces that sometimes people forget that disabled folks have the same kind of healthcare needs that able-bodied folks have. And I think a lot of times there's a misconception that like disabled people don't have sex or disabled people don't have to worry about HPV, which of course, as we know, isn't true. So I was really glad to see the person in the wheelchair on that ad, to see just how like, just taking like a disability justice approach to sexual health, which is really important.
Yeah, I really appreciated that as well. And I think that that's why the idea that the CDC was sort of focusing its energies on what they see as embracing the awkwardness of PAP testing really just kind of falls flat for me, because it's just beyond awkwardness. I mean, the expectation that everybody who has a cervix will be able to get on a table and do the things that are necessary to obtain the cervical sample, it was great that it existed as a step in terms of reducing cervical cancer like incidence and mortality, but we definitely can do better than that in terms of making the care accessible.
So someone has asked, what is the follow-up for a positive HPV test? Don't they still need to have a Pap test afterwards?
Yeah, so that's a great question. So for sort of specific people having positive HPV tests, the thing you'll want to do is follow like the ASCCP, like positive HPV guidelines. And it is true, for some folks, they will be recommended to either have a Pap test or go directly to a colposcopy. So where they're more able to they dry out the cells of the cervix and they take potentially a biopsy. And so I think that it is important to highlight that they could be required to have that more invasive testing further down the road. But I think what's important is that that will be because that is the best way to get that information at that point, as opposed to having that be the door for everybody to go through, whether or not they're going to need that level of examination. I hope that answers that question.
Someone else says that they've worked at a clinic where primary HPV testing wasn't available due to cost. Have you heard of this being a barrier in your experience?
Yeah, and it sounds like it's something that's sort of rapidly in flux as the insurance is sort of shifting to match the guidelines. It may be that person was under 30, and if the insurance was using the USPSTF guidelines, they were only covering HPV testing for folks over 30. That might be sort of the situation that came up. And I think one way that you could get around it is that you could order it as a Pap test with the HPV testing included. And they'll probably say like, there's not sufficient cervical cells to do pathology, but they may be able to report out the HPV part. I think I saw some providers do that at my last clinical site. So that might be an option. I don't know if that's too vague of an answer, but that might be one route to go. And I'm hoping that the insurance coverage will be able to continue to adapt to the American Cancer Society guidelines.
Another question says, do you recommend HPV testing over Pap smears? I think you kind of covered that. I'm going to drop in the chat a link to the American Cancer Society's recommendation. And they do support primary HPV testing, meaning like a self-collected swab. And then if someone has a positive HPV result, then it would be like Liz mentioned earlier, then you would have a speculum-based exam. But I think it's nice to have the option of self-collection, and then like have the speculum-based exam kind of be like a cross that bridge if we get there sort of thing.
Yeah, and I think patients are really owed that for each thing that they're asked to do to try to benefit their health. Like, you want to be able to tell them there's value in this. There's a reason that this is the next recommended thing. And so I feel like at this point, in terms of HPV versus Pap testing, especially for folks who are worried about doing a Pap test, you aren't able to say to them, oh yeah, we really, really need to do the Pap test right out of the gates. There's just not that evidence anymore.
And I think it's a really great option too for gender expansive folks and folks who are survivors of sexual abuse and sexual trauma. Because as you mentioned earlier, just like being in the position that you have to be in during a pap smear can just be so intensely triggering and difficult for folks. I think there was something else I was going to mention about it, but I think I've just forgotten it. Maybe it'll come to me right after. Any more questions from anyone before we go? All right, well, thank you so much, Liz. This was a really wonderful presentation. For folks who are still here, this is going to be up on the Washington AIDS Partnerships YouTube channel. Oh, someone's asking, will HPV testing be widely available without going to a provider?
Oh, great question. So actually, as I was preparing this presentation, I saw that the pay, sort of the out-of-pocket pay for the test kind of market that exists out there has started to include HPV testing. So I saw that like Everlywell, or I don't know if that's the brand name, but there's a few different companies that are offering at-home HPV self-testing. And so I suspect that that means that that's sort of where we'll kind of head eventually. But right now it's something that the cost is very high for for home testing. I think those tests seem to range from like $50 to $150. So that's sort of more a boutique angle of it, but hopefully that means that we'll move in the direction that other countries are trialing, which is to make people be able to take tests home, bring it back and turn it in, that sort of thing, to really continue to increase the accessibility.
Wonderful. I've dropped the Washington AIDS Partnerships YouTube in the chat. This video and the recording will be available starting tomorrow on our YouTube channel if you want to rewatch it or forward it to some friends. Thank you guys all for joining. Thank you, Liz, again for all the wonderful information, and enjoy the rest of your evening.
Thanks, everyone. Feel free to reach out with any more questions.